the topic of my talk will be the anti-cancer properties and prevention of bone mets, and I guess that we have to discuss maybe beyond that. Well, there's been numerous studies in the past 20 years on the effect of bisphosphonates, and they've been proven effective in the treatment of metastatic bone disease, and they also improved survival in various tumorous entities like lung cancer, bladder cancer, and multiple myeloma. We just learned from Dr. Blackwell that there's very good evidence that bisphosphonates also are very effective in the treatment of cancer-induced bone loss. There's been a number of studies out there for years indicating that, mostly preclinical, indicating that bisphosphonates demonstrate anti-cancer activity. And more surprisingly, maybe, there's also been a number of studies now. It's another fourth study out there, large-scale population-based studies, the WHI Israeli study, a study from the US, indicating that patients receiving bisphosphonates for the prevention and treatment of osteoporosis have a significant impact of the risk of breast cancer. In fact, it is reduced by 30%. So in fact, bisphosphonates are effective treatments, and the underlying question is, why? Can we explain these effects of bisphosphonates? And of course, there's one explanation, that bisphosphonates maybe have a direct anti-cancer effect, but on the other side, bisphosphonates may interfere in bone turnover. If we look at the vicious cycle of bone, we have the tumor cell on the top, and the tumor cells, in its activity, secretes growth factors like PTRHB, LA6, LA8, and a lot of others. And these growth factors stimulate osteoblasts and osteoclasts. Both of these two bone cells increase in number, in size, and in function. And with that, they increase the secretion of growth factors like BMPs, IGF, TGFs, FGFs, and others. And this again stimulates the tumor cell. So we have a synergy between tumor cells and bone turnover. Now, if we treat with bisphosphonates, we reduce osteoblastic and more so osteoclastic activity. So the secretion of growth factors from the osteoclasts on the right, it's decreased dramatically, and therefore the tumor growth will be reduced. Now the question is it the anti-cancer effect or the anti-cancer effect through bone turnover? Or what is more pronounced in which type of cancer? So let's look into the clinical data. And these are the old data with all Clodronate, the first bisphosphonate available for the treatment of metastatic bone disease. But there have also been data published with regard to adjuvant treatment. The first one, and I'm proud to say, was performed in Germany by a good friend and colleague, Professor Ingo Diehl. And he performed a study now with a 10-year follow-up, still showing an overall survival benefit after 10 years, 8.5 years. A much larger study from the UK, from Trevor Powell's, showed an overall survival benefit after 10 years. But unfortunately, there have also been two reports by Sato from Finland and by Patterson, could not repeat this effect. They could not show this effect, so we have some sort of inconclusive effect with regard to adjuvant use of oral Clodronate. Well, it's been proposed that maybe we should use an IV bisphosphonate, which is more potent, because with Clodronate and oral treatments, we have a compliance issue, so maybe IV treatment would be better. So a study was performed with 953 patients with breast cancer, and Christiansen has published this a couple of years ago, underlying that Pamidronate would not be effective in the adjuvant treatment. With zoledronic acid, we have a number of results in the preclinical setting indicating that there is an anti-tumor effect on inhibiting angiogenesis, decreased matrix invasion, decreased adhesion to bone, and it stimulates immune surveillance. But the question is, can we translate these preclinical results into clinical practice? Well, with regard to disseminated tumor cells, there have been a number of studies now, and I've plotted only 3 of them, one from Germany, from Iraq, from Aft and Lin, all indicating that the addition of zoledronic acid to the regimen led to a significant decrease of disseminated tumor cells, again indicating that there is an anti-tumor activity with the addition of a bisphosphonate. So now let's turn to the first case presentation. This is a premenopausal 43-year-old a woman with breast cancer from the University of Marburg. She's actually very bright and extremely well. She had a T1 tumor, 1.5 centimeters, got a breast-conserving surgery, sentinel lymph node biopsy, had a grade 2 tumor, infiltrating ductal carcinoma, no vascular or lymphatic channel invasion, estrogen receptor high positive, progesterone as well, HER2 negative, and the sentinel lymph node was negative, so a low-risk patient. She received radiation treatment, and now the question to you is, what would you recommend as a systemic adjuvant treatment to this patient? Tamoxifen only, LRHR, or as we say, GnRH analog and tamoxifen, GnRH analog and aromatase inhibitor, or chemotherapy plus endocrine therapy? Please vote now. Okay, so we have a sort of split. We have 1/3 would say GnRH analog and tamoxifen, 25% would say tamoxifen only is good enough. Chemotherapy plus endocrine therapy, another third. Well, okay. Let's go on to the next question. Would you also prescribe bisphosphonate to the adjuvant treatment? Yes, 1, no 2, or 3, I'm not sure. Please vote now. Okay, again, another split decision. 40% would say yes, 45% would no, and not sure. I would be interested if this was reimbursed in your countries, but that's a different question. So now let's turn to and if this may have an effect on your decision. Well, let's turn to the clinical data. You're all aware of this great and beautiful study performed by the Austrian Breast Cancer Group. And I might add, there were also some German patients in there, as Michael is in the room. ABCD12 was a landmark study because it included a large number of patients, 1,803. All were premenopausal. They had stage 1 or stage 2, no lymph node involvement. And they all received either tamoxifen or an anastrozole in addition to GnRH analoga. So we have premenopausal patient who had a total estrogen blockade, an estrogen deplete environment. And in these, half of them received additional zoledronic acid, 4 milligrams every 6 months. So this is not the metastatic dosing, this is an adjuvant dosing, 4 milligrams every 6 months for 36 months. We've seen the bone data in Dr. Blackwell's presentation, so I'll only focus on the tumor data. And as you see, disease-free survival benefit after 84 months of follow-up was 36%. So in addition to the maintenance of bone health, we have a significant impact on disease-free survival. And on the right-hand side, you see that this was not just restricted to distant metastases, most of them bone metastases, but also to visceral metastasis and to IPSIN local regional metastasis. So these results underline or implicate that there is a direct anti-tumor effect as well as an effect through bone turnover. And please keep in mind that this treatment was only given 36 months, as pointed out in the dotted line. And that's the point where the curves diverge. So we have a clear carry-over benefit after a 3-year bisphosphonate treatment for the ongoing 48 months. SOFAST, ESOFAST, and ZFAST, as already indicated by Dr. Blackwell, was a large-scale study. Altogether, there were 3 companion studies, had a pretty equivalent study design, and altogether about 2,200 patients were included. They were all postmenopausal, so they were already in an estrogen-deplete environment. And all of them on top, as an endocrine treatment, received letrozole. So we had a total estrogen blockade again in this patient population, and half of these patients were randomized to zoledronic acid. Again, the adjuvant treatment, 4 milligrams every 6 months, compared to no zoledronic acid. And in this very low estrogen environment, again, a very similar slide to the ABCD12. I 34% reduction in disease-free survival. In women, estrogen depletes. And this is again also true for local as well as distant recurrence, indicating that there might be a combination of anti-cancer effect as well as effect on bone turnover. It's fair to say that the ZFAST trial, which was much smaller, also had a clear trend in the same direction, but this did not reach statistical significance. And the ESOFAST trial, with only a follow-up 36 months and a much smaller patient population, could not show this effect. Safety profile, with the application of 4 milligrams every 6 months, flu-like symptoms with the first infusion, as we know, there were no renal toxicities and very, very few osteonecrosis of the jaw, none in ABCD12 and only 0.4% in the upfront Zol group in ZO and ESOFAST. So let's turn to the second case presentation. This is now a postmenopausal patient, 60 years old, with invasive breast cancer, no comorbidities. The tumor is slightly bigger, 2.5 centimeters. Pathology is grade 3, ductal carcinoma in situ, infiltrating ductal carcinoma, vascular and lymphatic channel invasion, highly estrogen and progesterone positive, HER2 negative, 2 axillary node positive, no distant metastasis. Post-operatively, she received chemotherapy and then radiation therapy. We performed a DEXA scan, and she was osteopenic with a T-score of minus 1.4 at lumbar spine and minus 0.8 at the hip. She planned to start adjuvant treatment with letrozole. Now the question is, based on the results of the clinical trials I've just presented, would you also prescribe an adjuvant bisphosphonate treatment with zoledronic acid in this particular patient? 1 is yes, 2 is no, 3 is not sure. Please vote now. Wow, thank you very much. I take this personally. Yeah, well, at least you will definitely benefit from it. That's true. And I think it's fair to say that guidelines, like the ESMO guidelines from 2009, where bisphosphonates were only recommended for the use for the prevention of bone health, in the 2010 guidelines opened a door because they stated that in premenopausal patients receiving AI or in postmenopausal patients on aromatase inhibitors, endocrine upfront Zoledronic may be justified. So the door is open, and it's up to your clinical decision making, and of course up to reimbursement issues if patients receive this bisphosphonate treatment or not. Well, let's turn to AZURE, because that was the study where we all hoped after AZURE everything is clear, and AZURE in fact is very, very different to all the other studies I've just alluded to. Well, let's turn to baseline characteristics. We have 3,360 pre- and postmenopausal patients. They were not early breast cancer, like in ESOFAST, ZFAST, and ZOFAST, or in ABCD12. They were stage 3, stage 4. 75% received chemotherapy. But this was, the primary endpoint of this study was disease-free survival. But the dose regimen, of course, was very different to what we've seen in adjuvant study before. This was a mixture of pre- and postmenopausal patients, of patients with high estrogen levels and low estrogen levels. Well, the Neoadjuvant was very promising because here the addition of zoledronic acid in about 6% of the total population, which was neoadjuvantly treated with bisphosphonates, showed a 44% reduction in residual tumor size, 8% reduction in mastectomy rate, and of course a twofold increase in pathologic response. So yes, we thought and we were pretty assured that we would have the results we expected. But if you look at ABCD12 and ZOFAST, like in this table, we see a lot of similarities, but discrepancies also. Of course, ABCD12 was performed in premenopausal and ZOFAST in postmenopausal. But both of these studies were performed in patients with an estrogen blockade, with an estrogen deplete bone environment. This is important because on the left side you see premenopausal patient, and with circulating estrogens you have a balanced bone turnover. In the middle you have postmenopausal patients, and with regard to the reduction of endogenous estradiol levels, you have an increase in bone turnover, and you have a decrease of bone mineral density of about 1% per year. Now, if we add in this postmenopausal situation aromatase inhibitor, for example, we will again increase bone turnover, and if you remember the vicious cycle, then of course the further increase of bone turnover will increase circulating cytokines, which could have an effect on tumor cells. So let's focus on clinical data, and in fact, exactly that's true. This is a study performed on patients, postmenopausal patients, who already had an elevated bone turnover, receiving anastrozole on the left side. And after 12 weeks, you see a 50% increase of bone turnover. So these were postmenopausal patients, had an increased bone turnover, and again, another 50% increase. The same is true for letrozole. If you see here the results of the ZFAST trial, you see in gray, women only on letrozole, and after 3 months, they had a 30% increase of bone resorption. But if you give a bisphosphonate, as in the lower red line, you see that bone turnover is markedly reduced by 30%. If you now return to the AZURE results, you see that the menopausal status is essential. And in fact, 45% of the patients have been premenopausal at study entry. 5% have been somewhat early postmenopausal, and 14%, I'm sorry, and about 30% have been clearly postmenopausal at least 5 years after menopause. And of 10%, the status is unknown. And this is extremely unfortunate because the point I tried to make in the past 50 minutes is that the estrogen environment is important for the efficacy of adjuvant bisphosphonate treatment. And in AZURE, unfortunately, we neither have the information on serial endogenous estradiol measurement to say these premenopausal patients after chemotherapy got postmenopausal. And we don't also have at least the information of the patient, do you still have your menses during the study? So with these two missing informations, we have a mixed population of pre and postmenopausal, a mixed population of women with high estrogen levels and low estrogen levels, and that's why I think that the results are explainable. Well, we have no effect on disease-free survival and over-survival in the total population, which is mixed between pre and post, high and low estrogen levels. If we now add the group which was a pre-planned analysis of patients over the age of 60 who were clearly postmenopausal, clearly a low endogenous estradiol level, then you have the results which you're probably all aware of. We have a significant decrease of disease-free survival and a 29% increase of overall survival. So yes, in estrogen-deplete patients, in pre- and postmenopausal patients, bisphosphonates have been shown effective. In women with high estrogen levels, we simply don't know. So the safety of AZURE, and it's just been published 2 days ago in Breast Cancer Research and Treatment. SAE have been pretty balanced. We have very little renal AEs. The incidence of ONJ with 1.6%, pretty equivalent to what we just learned last year. But 9 out of 11 patients with an ONJ just had a dental extraction, why it is so important to talk to the patient, to perform dental extraction or dental procedures before bisphosphonate starts or prolonged bisphosphonate treatment until the healing is complete and given antibiotics with it. So for that patient now, would you use zoledronic acid for potential anti-cancer effects during adjuvant treatment in breast cancer? Yes, in all patients. Yes, but only in patients with low estrogen levels. Yes, but only in patients with low T-score for bone health reasons. No, or I'm not sure. Independent of reimbursement issues in your country. Please vote now. Nice, thank you. There will be a number of more studies which are ongoing, which will be presented. You see large-scale studies, the NSPABP, B34, or AZURE has been published, Success, a German study. So we will have more data. And I'm pretty sure from all we know today that the estrogen deplete patients are the one who will benefit. And on the other hand, we have to state that women with circulating estrogen or high estrogen levels today possibly will not benefit from an adjuvant treatment with regard to disease-free survival, not with regard to bone health. So in conclusions, bisphosphonates are the current standard of care for metastatic bone disease, and I think there's no doubt about that. But a number of phase 3 trials have demonstrated anti-cancer benefit with the addition of ZOL in the adjuvant treatment, only in patients with very low estrogen levels. So, even in AZURE, these results have been shown, even with an overall survival benefit. I think the adjuvant benefit from zoledronic acid or other bisphosphonates in patients with high estrogen levels are yet to be established. We don't have data, and therefore, I don't think it's fair to use them. With this, I'd like to end and state that bisphosphonates have been around for a long time. We started in the metastatic session, and now we're turning to adjuvant. It's a very exciting time. I'd like to thank you for your attention.